Dr. Sugarbaker, thank you so much for making time to be with us today as we happily remember Gabriella Graham and think of the great work that she did starting this organization and propelling us to do what we do today, continuing her memory. So thank you so much for making time for this. I have a few questions I'd like to ask.
My pleasure.
What is it that HIPEC does that is so essential in the treatment of pseudomyxoma peritonei?
There's no doubt that there's two essential components to the successful long-term management of pseudomyxoma peritonei. We all know that the number one requirement is this complete removal of all visible disease. But this is a strange malignancy where there is a large component of mucus, which is infiltrated by tumor cells, and it's impossible for anyone to remove that layering of mucus on the both parietal and visceral surfaces of the inside of the abdomen and pelvis. And what HIPEC does probably more efficiently in this disease than in any other disease is get into and penetrate into that water-soluble mucoid material. And within that mucinous material are tumor cells, and these tumor cells are then eradicated. The mucus is very superficial. It's not like an invasive malignancy, say like gastric cancer or ovarian cancer, where the chemotherapy actually has to get into the vascularized nodules. We don't have any vascularized nodules after the cytoreduction, so we just need to cleanse the residual mucoid debris, and in so doing, we can do what we don't do very well in a lot of other peritoneal surface malignancies. We can actually eliminate that last cancer cell. So it's cytoreduction and then HIPEC, and of course we have to be very careful that the HIPEC gets distributed uniformly, both the heat and the mitomycin C. Usually we're using mitomycin C. They get distributed and all of the surfaces get cleansed. One little area doesn't get cleansed 5 years, 7 years later, there we go, we've got a recurrence.
So why must all the disease be removed by surgery prior to the initiation of the HIPEC treatment?
Well, that's a great question. And all too often, a surgeon who's being stressed by the extent of the disease will say, oh, well, we'll leave this component of the disease for the HIPEC. Bad idea, because the chemotherapy, this is a aqueous chemotherapy solution, it only gets into the tissues by simple diffusion. There's no active transport of the chemotherapy into the tumor. So by simple diffusion, we can only get into a few cell layers depth of chemotherapy penetration. So it's absolutely essential in pseudomyxoma, and this also goes for the other peritoneal surface malignancies that we're treating now on a daily basis with cytoreductive surgery and HIPEC. We really need to have all of the tumor removed that my eye can see, and then the HIPEC will do what we want it to do. But it's very limited penetration of the residual tumor. Of course, we're working on that now to try and use nanoparticles and to use drug combinations and to use combined intravenous and intraperitoneal chemotherapy in the operating room. So we're trying to get better at this penetration problem with our research work, but for pseudomyxoma, simple installation into the peritoneal space seems to be successful.
Excellent. That makes sense. What is the fundamental difference between surgery for PMP and other causes of peritoneal metastases and other cancer surgery procedures?
Well, Chris, as you know, cytoreductive surgery is now expanded to the general surgeon. And that's good in that these treatments are going to be available to more people, but maybe it's not so good in that the expertise for performing cytoreductive surgery may not be as well understood or as well practiced. You know, surgery is a craft with a bioscience base. Most general surgeons, now to get to the answer to your question, most general surgeons do not perform peritoneectomy procedures. So the crucial surgical invention that led to success with pseudomyxoma, and that was the initial success with the treatment of peritoneal metastases. No doubt about it, historically speaking, PMP was the first success story. And in order to make it work, you've got to perform extensive peritoneectomy. Sometimes the entire lining of the abdominal space is removed. And thanks God, the intestines compensate for that and work extremely well, even though this delicate and beautiful lining has been completely removed. The nuance, the difference between the general surgeon's activity and the cytoreductive surgeon's activity is this ability to perform extensive peritoneectomy and thereby bring about a long-term good result. People have done studies, and we've done them also. Sometimes the parietal peritoneum, that's the peritoneum that's on the body side of the abdominal space. Sometimes that parietal peritoneum will look pretty much completely normal. But if you remove it and then subject it to histologic study, you'll find out that it's infiltrated by tumor cells. So we've got to perform the for mesothelioma. It's absolutely 100%. We've got to get rid of that parietal peritoneum. And I'm not so sure, you know, that there's a lot of teaching in surgical oncology programs now about peritoneal surface malignancies. But I'm not sure that the general surgeon knows the absolute importance of peritoneectomy and how to knowledgeably apply this technology for peritoneal surface malignancy patients.
That makes a lot of sense. And we're certainly aware, and we educate patients that the experience of the surgeon in the hospital is vital and important.
Yeah, the surgeon, what happens in the operating room is, of course, extremely important, but there's no doubt that it's a team effort for 2 to 3 or sometimes even more weeks after this surgery.
Dr. Sugarbaker, are there any changes in the patients that you're seeing now as compared to 35 years ago when the first successes with treatment of PMP were reported?
There is a huge change in the patient population that we see with appendiceal mucinous neoplasms are what we call clinically pseudomyxoma peritnei. The awareness of the general surgeon who's performing appendectomies has changed. You know, through the efforts of PMP Pals, through the efforts of our really hundreds of publications, the people who are taking care of appendicitis and doing the majority of the general surgical care on patients who have a complaint of abdominal fullness or right lower quadrant pain. They are now aware that there is a treatment, rather than just saying to these patients, oh, you're going to need an operation every 2 or 3 years for the rest of your life in order to remove mucus or a mucinous tumor. These patients are referred. They're referred as the initial diagnosis is made. Chris, the interval between diagnosis and definitive treatment used to be on the average over 3 years. You know, when we started back in 1985, most of these people were referred only as they developed the jelly belly. Now patients are referred with a diagnosis of pseudomyxoma peritnei, but they're referred 3 months, 6 months after they get their surgery, 3 months or 6 months after the diagnosis is made. And it has made a huge difference in what we're required to do in the operating room. And I might say that now those 12-hour procedures, they usually are coming from overseas. And for the most part, the surgical procedures that we have here now are 6 to 8 hours, but they're not the horrendous mother of all surgeries as it's been referred to. And you know, that's good, because the extent of disease does in some respects determine how well the patient is going to do long term. So the disease has changed, and the major cause for the change is earlier referral.
In my own case, I have always considered one of my luckiest breaks is that my diagnostic surgeon had seen one case before in his career. And 16 years ago, that was a pretty unique thing. So I understand what you're saying. That makes sense.
Yeah, thanks God. That's right. That this general surgeon had in his little personal computer this experience with a previous patient.
Yeah.
Yeah.
Yep. So, Dr. Sugarbaker, we talked about penetration earlier, and of the mitomycin C into the peritoneum, the depth of that chemotherapeutic agent going a couple cell layers deep. We're learning more now about a relatively novel treatment, certainly here in the United States. It's more frequently done in Europe and other parts of the world, but it's called HIPEC, right? So pressurized intraperitoneal aerosolized chemotherapy. What role do you see this new technique playing in the treatment of PMP patients?
Well, I'm hopeful. I'm hopeful that it's a valuable addition to the, as we say, the armamentarium by which we will achieve optimal outcome with peritoneal surface malignancy. The PPAC delivers about the same amount of chemotherapy. So the doses of chemotherapy in PPAC are about 1/10 of the doses of chemotherapy in HIPEC. It's a much lower dose, but the chemotherapy is not diluted in an aqueous solution, as is HIPEC. So the chemotherapy is in an aerosol. It goes to the tissues, and would be there in fairly high concentration. So that's one difference between PPAC and HIPEC. Now, the single PPAC is not effective. And PPAC is different again from HIPEC in that it's used repeatedly. And if you ask me, and it would be a good question, what are the major drawbacks to the effectiveness of HIPEC? First on my list would be, at least HIPEC, the way we're using it now, is only a single treatment. The cancer only sees the chemotherapy as a regional treatment once. PPAC is done 3 times, 4 times. I think the limit is 17 now, 17 treatments in a patient who seemed to be doing well. So this repeated installations of cancer chemotherapy is, I think, what's responsible for the success of PPAC. Now, there are a number of success stories with what's called NIPEC. And in actually this month's Annals of Surgical Oncology, my own experience with repeated installations of chemotherapy in mesothelioma is published. So if you're clever enough to have a catheter that goes into the peritoneal space, you can deliver 4, 5, 6, usually not more than that, installations of chemotherapy directly into the peritoneal space. If you ask me what's the greatest drawback of PPAC, I would say it's expense. Every time that you perform PPAC, the patient has to be worked up for surgery. They have to come into the hospital. They have to have a laparoscopic examination in the operating room. They have the PPAC, which shuts down the operating room for at least 2 hours because you've got to instill the drug. Everybody has to leave, and then the environment has to be cleared. So it's an extremely expensive, repetitive treatment. Whether it will ever be approved by insurance companies in this country with that sort of expense, I don't know. I'm hopeful that we can learn how to do it a little bit more efficiently.
Sure.
And you know, the nice thing about a PPAC, and we did this on all of our original research, you're able to see. You know, radiologically, we don't have a handle on what's happening in the peritoneal space. It's only when the tumor really gets up to golf ball, tennis ball size that we're really able to see what's going on. With PPAC, you're actually looking. So when you do this treatment, usually on a monthly basis or every 3 weeks, you're actually looking into the peritoneal space, and the surgeon can say, aha, I looked at that area 4 weeks ago and there were tumor nodules now. And now after I've sprayed with the chemotherapy, those nodules are much smaller or they've gone away. Now there is a regional component to PPAC. Now they're saying, oh, well, it gets all over the abdomen. Well, yes, it gets all over the abdomen if there's no adhesions. But PPAC has the same problem with spaces being closed off to, we say, bathed. Is it chemo bathed? Is it actually in contact with the aerosol solution? So you can, though, get around that a little bit in PPAC by doing laparoscopy in different quadrants. So they don't always go through the same laparoscopic port site. They may move it around so that their distribution of the chemotherapy agent becomes a little bit more uniform. So yeah, I like the idea of PPAC. I have not used it myself. I've watched it being done on a couple of occasions. And of course, right now, it's basically used for palliative treatment of ovarian cancer and gastric cancer. And it seems, especially in gastric cancer, to be able to give some good palliation. Of course, what we're trying to do with a lot of these treatments in patients who have peritoneal metastases is find the super responder. Find that patient who really has an excellent response to PPAC, that the disease on the peritoneal surfaces is eradicated, and then they become a candidate for what we call conversion surgery. So for me, the major goal for, say, 6 cycles of PPAC in a gastric cancer patient is to select those super responders who can then have a complete resection of their disease and go on to some, maybe not cure, but go on to 4, 5, 7 years of good quality survival.
Absolutely. We couldn't agree more at PMP Pals. You know, as we support patients through the entire continuum from diagnosis through preparation for typically HIPEC or
yes,
those types of procedures, you know, we do have those patients who are inoperable, where the disease burden has gotten too high. It may be on the small bowel. And these are tough patients without many options. And so
yes,
we agree, and we've heard that there is this conversion, you know, maybe upwards towards 1 in 5 patients on the outside are being converted back to operable patients. And we think that's a wonderful thing. And, you know, we believe, as Gabriella taught us, that patients deserve choices and options. And we think it's a real opportunity. So that's great.
So I'll just give you a little anecdote here, Chris. Now, this is not PMP. This is colorectal cancer. But I think because PMP is the grandmother of all of these other treatments, PMP should take some credit. PMP Pals should take some credit for these other diseases we're beginning to treat. We have found, and your number 1 out of 5 is almost perfect, about 20% of our colorectal cancer patients will have a, we say, complete or near complete response to their systemic chemotherapy. Okay, 1 out of 5. And if those patients then go to surgery right at the end of their neoadjuvant chemotherapy, that's within 6 to 8 weeks after the chemotherapy is finished, the neoadjuvant chemotherapy, or chemotherapy before surgery is finished, that group of patients has an extraordinary long survival. And what is happening, I think, and this is in the discussion of the manuscript, what I think is happening is that the systemic chemotherapy is causing this remarkable downstaging of the disease, and then the cytoreduction comes in and removes, with HIPEC, the cytoreduction with HIPEC comes in and gets rid of that small volume residual disease, usually just 4 or 5 places around the abdomen and pelvis. And we come up with a median survival of 7 years. This is for colon. This is for colon. So you'll find that manuscript coming out fairly soon. But this dynamic duo of super responder followed by a planned cytoreduction is really a spectacular treatment for high-grade disease. Now, that's the good news. The bad news is that everybody gets treated with neoadjuvant chemotherapy, and 8 out of 10 aren't really benefiting at all, because if we ask if people have a partial response, you know, the disease shrinks maybe 50% or maybe even 80%, do they profit? They do not. It really is only those patients who have the complete or near complete response, and then the durability of that chemotherapy response is really markedly prolonged by the cytoreduction with HIPEC.
Good. Well, without this work, we wouldn't know that 1 in 5 are super responders to the intravenous chemotherapy. And
correct,
then, this aggressive HIPEC approach is, it's remarkable. I mean, it truly is. I think when we think about stage 4 cancers, whether it's colorectal cancer or pseudomyxoma peritonei, you tell me, I mean, are there other diseases where we've had this type of responsiveness, where we've had, such good survival in stage 4 cancer? I mean, it's really remarkable. And I remember, I'm going to forget his name. The original surgeon at UCSD, I'll have to look him up. Gabriella loved him.
UCSD, University of San Diego.
It was before Dr. Lowy.
Before Lowy? Not Barone?
No, not Bob.
Oh, Barone's another, it's in San Diego, but another group.
I remember he said to me at one of these conferences, I'll look up his name. At one of the conferences, he came to me and he said, if you had to get cancer, this is one of the ones that you probably want to get. And it took me years to understand what he meant by that. But yeah, I mean, we're lucky that we have this technology that you've brought to patients, and not just spread across the United States and North America, but truly around the world. So we're very grateful for that, for sure.
Well, Chris, I would say, I think that there's a really some very interesting things happening right now with the use of chemotherapy in these high-grade diseases prior to surgery. And we've got a lot of work going on right now trying to use bidirectional neoadjuvant chemotherapy. In other words, rather than FOLFOX being given all into the vein, we know that 5-FU is a terrific a drug to use within the peritoneal space if you use it repeatedly. And the oxaliplatinum is a terrific drug to use systemically. So we're trying to use this combination of intravenous and intraperitoneal chemotherapy to prepare patients for a cytoreduction. And I think it's going to be much more successful than just systemic chemotherapy alone. Is it a little bit more intricate? Does it require an access device? We've got a lot of work going on new access devices, new things, new ways to get chemotherapy into the peritoneal space without this cumbersome intraperitoneal port. And I think it's really exciting, the progress that we're making with peritoneal access, and then long-term intraperitoneal, combined intraperitoneal and systemic chemotherapy. By the way, PPAC is always combined intraperitoneal and systemic chemotherapy. You get your PPAC treatment, 2 or 3 days later, you get your systemic chemotherapy. You get your PPAC treatment, 2 or 3 days later, you get your systemic treatment. So they're into this bi-directional approach, and we are also, what we're trying to do with our clinical studies is considerably less complicated and doesn't require repeated laparoscopic surgery.
Fascinating. I did not know that it was a bidirectional approach with the PPAC. That's I did not know that, so good to know.
I don't know a single PPAC protocol that is just aerosolized chemotherapy into the peritoneal space. It's always a combination of the best systemic treatment along with the intraperitoneal drugs which are appropriate for that particular disease.
Great. It was Dr. Walt Merdinger.
I don't know Dr. Merdinger.
Dr. Merdinger
did not have the pleasure of working with him.
When I met him 15 years ago, I want to say he might have been in his 70s at that point in time. But with his, I believe it was with his passing. I'm not sure if Dr. Lowy was there together with Walt or not, but anyways, I remember him from the early conferences. You know, I'll share a memory with you. I remember
Sure.
seeing you speak in Aspen. So 15 years ago, I went to Aspen and I attended the symposium, the regional therapy symposium. I think UPMC was the sponsor at that point in time. And I
Yes.
got to see you speak, and that I loved seeing that and being educated, and learning more about the disease, and hearing your particular knowledge as you talked about the disease and spoke to the other surgical oncologists. So anyways, I was there and I remember that.
Well, I remember snowboarding at Aspen. It was a great experience. I learned to snowboard at Aspen. I think at that very meeting.
That's great. That's great. You know, when I started snowboarding, I think I've put skis on one time since.
That's
I really,
right. Yeah,
I
same
enjoy
here.
snowboarding too.
Yeah, yeah.
That's great. That's great. Well, speaking about education, some of the questions I also want to ask, you know, about patient support. What do you think is the importance of patient education? Obviously, I mean, this is it's a very challenging disease, from understanding how it works and propagates in our bodies to the complicated treatments and the options, and, you know, navigating intravenous chemotherapy and HIPEC and cytoreductive surgery, and then the recovery from it too. What is the importance of patient education in this environment?
Well, this recent COVID era
Mm,
has really been extremely difficult. And we have seen time and again how important it is to have the patient educated, to have the family prepared to support their loved one in the hospital, and then after they leave the hospital. It's just been pointed out to us almost in every case that trying to go through the cytoreductive surgery with HIPEC in the 14 to 21 days in the hospital, and of course we're still using very often when it's indicated the EPIC, which adds an element of discomfort and prolongation of treatment. Anyway, we've just been shown up front that the family has to come into this support system. We had a few people who definitely had a break with reality. Really solid people who didn't see a familiar face for 2 weeks, and it was just too much for them. And I have to say that our nurses on the 4E nursing unit did absolutely everything they could. And I sat down with these patients sometimes for a prolonged period, but that's not enough. So education, family support, PMP Pals support, I just cannot emphasize it more. It's just something that has to be a part of the treatment. Now, having said that, I'm pretty much convinced that once you get through this very rough 3 months after a cytoreduction with HIPEC, you can live a completely normal life. And there are instances where we need to shorten the bowel, and that can be a problem. And there are some times where we have to create an ostomy, and that can also be a detriment to a quality of life and a person's vigor and their willingness to thrive. But for the most part, when I look at 1,200 patients, maybe a few more now that have had the treatment for appendiceal malignancy, I don't see any nutritional cripples. Basically, virtually all of those patients have continued to have finally done well.
That's great. You know, COVID, the pandemic, has been very difficult, but there's also been some miracles that have happened. So
Yeah.
PMP Pals started doing Zoom calls in May of 2020 because patients just needed connection. They needed the education. The
Yes.
caregivers needed information,
Yep.
and it's turned out to be incredibly popular and amazingly supportive and welcomed by all the pals. It's given us the opportunity not just to be there to support them emotionally. In the period of a month, we do call it 4 meetings. 3 of those meetings are roundtable support discussions where we just allow
Excellent.
patients to ask questions and start to navigate this decision process. Caregivers get to ask, what's it going to be like when, my husband or my daughter gets home, right? So we've had this opportunity to engage on a deeper level as mentors and advocates, and teach people how to engage. And we go for 3 hours on a support call every Saturday, and it's been just
Wow.
phenomenal.
That's wonderful. That's great.
Gabriella Graham, we had an annual conference of PMP Pals in Monterey, California. About October every year, we would have a conference, and the Zoom calls, they feel like a conference every week.
Really? Excellent.
Yeah, it truly does. And there's just something magical about patients talking to one another. When it's a rare cancer, you feel isolated and alone. And the pandemic has made us feel isolated and alone in a grave way. And the Zoom calls have allowed us to connect with one another and just be with one another and just share their stories. And it's been really helpful for our emotional state. Likewise, in that 4th week, we have physicians come and present and educate, and we have had so much great education and learned so much. And we've had over 100 patients on a Zoom call, and I'm sure a higher number will be watching this conversation too, on the edge of their seats to get educated. But this has been one of the silver linings of this very tough time. And likewise, we've had patients call in after HIPEC, just a couple days after HIPEC, and be on the video just for a brief couple of moments, but letting patients know just what you've learned, that we really can thrive. We
Yes.
do get better. It's not an easy procedure. It's a difficult one. It's a journey, and it does require support from our families. But you can get through it, and you can thrive, and we can return to a happy, productive life afterward. And so that's been one of the things we've learned through the pandemic.
And I like taking care of appendiceal mucinous neoplasms, Chris, because it's one of the few instances, well, the pseudomyxoma and the malignant peritoneal mesothelioma, it's one of the few times where you can look the patient and their family right in the eye and say, in my experience, and I've done this quite a few times, you have about an 8 out of 10 chance for being alive and well 20 years from now.
Mhm.
And that is somewhat unique in terms of our experience in oncology,
Mhm.
but it is a fact. And so I always do whatever I can to instill hope, because many of these people have been told you have 6 months to live.
Oh yeah.
Still, they were told you have 6 months to live.
Yeah.
So instilling that hope, and it's not a false hope, it's a realistic hope,
Mhm.
is I think very important in trying to educate the patient with pseudomyxoma peritonei. Now, we're not talking about the high grade mucinous adenocarcinomas with signet ring or the adenocarcinoids. We're talking about the run-of-the-mill peritoneal mucinous neoplasm, often referred to as pseudomyxoma peritonei, and it should be cured.
And that is the bulk of our disease, as I understand it, for appendix cancer. Most of it is that type of
Yeah, about 80%.
that.
Yep. Yep.
Good.
Yep.
Yeah, that's what we've learned. We've been educated. So good. Good. You know, you may or may not remember when I was diagnosed in 2004. I met Gabriella. Gabriella had a website, and that was a pretty new thing in 2005.
It was, yeah.
Yep. And so I found PMP Pals on the web. My father found the website, and then I called Gabriella, and I had gone to some notable hospitals. I won't mention their names, but you know, they didn't have this same knowledge and experience. And at that time, there was many surgeons who thought that HIPEC was far too aggressive and that mortality was higher. We know that's not true today, but I was given a 1-year prognosis.
Really?
And
Wow.
Gabriella said, "You're going to go on a trip." And so I went and saw Paul Mansfield at MD Anderson. I went to NIH, and I actually went to see you. So I consulted with you, if you remember that or not.
I
And you
don't
actually,
remember that. No, no.
you shared those same percentages with me, that you,
Yeah.
you were
Okay.
confident that I had an 8 in 10 chance of having a long survival. And here we are 16 years later. So
Right. Yeah.
yeah, good. Now I'm going to show you something. I'm going to share my screen with you. You
Okay.
sent Gabriella a letter of gratitude and thanks at one point in time, thanking her for the PALS mentor program. And as you see this letter here, you wrote that to her, expressing your thanks, and how important that mentor program was, right, for such a frightening surgery. Talk more about that, right? This was back in 2001, I believe it was. And so,
Okay.
like almost near the anniversary of that, as a matter of fact. You know, June's a pretty big month for us. Gabriella passed on June 18th, and Father's Day was her favorite holiday. And so anyways, it's a pretty important month for us. But yeah,
What was
tell me about,
6/18 and what year?
she passed in 2014 with PALS by her side.
Well, this letter from me is 2001, so it was 13 years prior to her passing. Well, yeah, the letter was written with a lot of gratitude for this mentorship, which she set up so that the people didn't go through this treatment, this extended treatment on their own, wondering, you know, what's going to happen, you know, tomorrow. They pretty much had a good idea as they went into the hospital, you know, from the CT scan to the bowel prep to the epidural anesthesia to 10 hours of surgery and then 2 to 3 weeks in the hospital. I think it was a huge help for them to be educated as to what was going to happen, and they just, you know, they didn't wonder every day what was going on, and then they had this feeling of accomplishment as they saw themselves basically staying on the timeline for recovery from the disease, and then you know, pray to God we didn't have any wound infections or fistulas or take backs to the operating room with post-operative bleeding and that sort of thing, which can happen, but you know, it was really very valuable for patients to stay on that timeline, and it gave both the patient and their family a lot of confidence, and much less anxiety to know that this was going to be over, and they were moving through the process in an organized manner. Yeah.
Yes. We tell patients you have to rest more than you think. It will take a bit longer than you think,
Yes.
but every day does get better. And it is 2 steps forward and 1 step back, at least.
Sometimes it is. Yeah.
As patients,
Yeah.
you know, it's just some days are good and other days are challenging, but in aggregate, they get better, and
Yeah.
we do better, and we progress. And so, but yeah, it takes support. It takes support. We have learned, as invasive as this procedure is and physical as the recovery is, we actually find the emotional battle is greater.
Really?
We find the need for emotional support is
Yep.
actually, the emotional battle is more difficult
Yep.
than the physical battle. And
Yep.
so that's been our experience. And so we are just repeating, we're paying forward what we learned from Gabriella and what we watched her do for hundreds of people, truly. I had the pleasure, I lived in San Jose, California. She was down an hour south in Salinas, California, very,
Uh-huh.
very small farming town. And so I would visit her quarterly, and my daughters were raised with her. And she was not just responsible for saving my life, educating me and getting me to care, but she was a dear friend, a confidant, and I was privileged to know her. I was lucky to be able to spend a week with her at Shadyside at UPMC when
Mhm.
she had had surgery with Dr. Bartlett,
Yes.
and I was with her at Stanford when she passed. And so
Hmm.
just a miraculous woman, this diminutive person who was never free of disease, and yet she gave, her life's mission was to support us and be there
Yeah.
for us with no compensation or anything in return other than the knowledge that she was helping us. Truly an
Great.
amazing individual. Do you remember seeing the PMP Pals table at various conferences and
Oh,
symposia?
absolutely. Yes, I remember it here in Washington, D.C. at the 2016 meeting. That was an important meeting for us. I remember the meeting in Paris with um, your table there, and that was a spectacular event for the whole SOGI, Peritoneal Surface Oncology Group International effort.
And so let me ask you this, right? So you actually were a recipient of the Gabriella Graham Award in
Yes.
its infancy. And so what did that mean to you when you received that award?
Well, I received that award, if I'm not mistaken, at a meeting that was held in Philadelphia. And it was a really great event. Um, it was very encouraging to me that the research that we had done, looking for that magic bullet, the magic bullet. The magic bullet is a chemo treatment that will preserve 100% that surgical complete response. And we haven't arrived at a magic bullet, but we've come a long way. Our chemo treatments now are really much better. Now we need to popularize these new bidirectional chemotherapy plans, because a lot of people are still just using moderate dose mitomycin C, which is okay for pseudomyxoma, but not okay for the high grade malignancies. But it was a real encouragement to me to continue our efforts to optimize, to educate, so that optimal treatment could be delivered at 150 plus centers throughout the United States. And then Ignace de Hing from Eindhoven tells us that there are over 1,000 centers around the globe. And we'd like for all of them to be able to deliver an optimal treatment. And I think that's what Gabriella would like to see also. I think she would like to be a part of this expansion of the efforts of the PMP Pals Network.
Well, and certainly, program certification, it could be something that's really important, right? As we look at all these new centers, we have surgical oncologists that are, newer to this procedure and learning. Certification and training may be an important part of expanding and making sure that everyone has the greatest capabilities as this expands around the world. So,
SOGI is much more active in Europe than it is in the United States. And the reason for that is that we've been able to set up there an infrastructure for certification. And we have the ESPSM, the European School of Peritoneal Surface Malignancy.
Yes.
And it's been a great help in trying to make sure that people who are now taking on primary responsibility for treating patients with peritoneal surface malignancy, that they really do know what they're doing. And we just don't have any certification in the United States. Anybody who wants to use HIPEC, they can call one of the commercial groups and they'll come in and they'll deliver HIPEC for a fee. Doesn't mean that they had a reasonable side of reduction. It just means they had HIPEC. And of course, you and I know that HIPEC without complete cyto is usually not very effective. So we have not been able to set up in the United States that really in-depth training. Now, what has happened in several localities is a centralization of the treatments. And I'm sure you realize that the most active center for management of appendiceal malignancy at this point in time is Basingstoke, and then Basingstoke also now in Manchester, England. And they're treating about 250 patients per year.
Wow.
And then Manchester, perhaps 100 patients per year. So that pseudomyxoma peritonei machine that they have going there in Basingstoke is what I would have liked to see happen, say at the Washington Hospital Center, but it was not. It was just not something that we could. We did it for a while. We had our machine up and running for about 20 years, but it wasn't something that was popular with the medical community in the United States. It's pseudomyxoma peritonei treatments and peritoneal mesothelioma treatments are basically spread all over the country. And people would rather have their treatments near home. I can certainly understand that. But I also would like to see some centralization of the treatments for pseudomyxoma peritonei and for peritoneal mesothelioma. And as a matter of fact, I would like to see that for colorectal and ovarian and gastric also. You know, real centers of excellence that are accredited, that have to have a certain number of cases and have to present their results on a regular basis. You know, you're not required as a surgeon in the United States to present your results to anybody. You're not required to keep track of your adverse events and explain that to anybody. There's really no monitoring of, and certainly there's no, the tumor boards are just almost non-existent now. You know, you just don't really, tumor boards are a very expensive thing. And tumor boards are not really keeping track of what's happening with patients treated for peritoneal surface malignancy. So in some respects, we've gone backwards rather than forwards because the monitoring of the outcomes short term is moderately well done. But monitoring of what happens long term is a big problem unless you're in a center of excellence, which is looking out as to what happens to their patients on a yearly basis, getting follow-ups and you know, making sure that they know what's going on. In order to do that, you have to have a centralization of the process or some sort of accreditation.
Yeah.
And I don't see it happening in the United States, but it has happened. Certainly, it happened in England. It happened in Italy. It is very much a part of treatment in Switzerland. Germany, also, it's pretty hard to get things paid for in Germany unless you're part of the consortium there. Norway and Sweden, 6 centers, and that's it. So I would say the quality of care in Europe is considerably different than it is in the United States. And the reason for that is this centralization of these more intricate surgical treatments.
So one final question comes to mind. So Professor Morris's BROMAC trial, so the advancement of bromelain and N-acetylcysteine in combination of those two enzymes working to break down the mucinous jelly in the abdominal cavity. What role do you see this treatment playing?
Chris, I don't know. I've had several patients go to Australia and treat, and were treated, and I think that the treatment is being used in some places in Europe now on an experimental basis. I think it makes sense that you try and liquefy the mucin and then suck it away. And there are, I think, some people who have profited. I've seen some pictures of, evacuation of very large pseudomyxoma accumulations that have been liquefied and then aspirated. I think that trying to deal effectively with mucus is important, and it may be that the treatments that dissolve mucus may be even more important, like in a HIPEC regimen, where we could not only infiltrate the mucus with chemotherapy, we could actually get rid of any residual mucus by this solvent, this mucoid solvent that Dave Morris is developing. So yes, I think that there are indications where it can palliate patients with pseudomyxoma, but I also think that its broader application to mucinous malignancy for colon cancer, for pancreas cancer, for gastric cancer, ovarian cancer doesn't often have a mucinous component. It's not a gastrointestinal malignancy. It's the gastrointestinal malignancies that very often have this mucinous component. But I think that what Dave's working with is very interesting and may indeed have some very important long-term applications, not only for pseudomyxoma peritonei, but for the management of mucinous peritoneal metastases. If you read some of the older literature, the mucinous tumors were always regarded as the worst. And of course, we don't see that now that we know how to do peritoneectomy and HIPEC. As a matter of fact, I'm more comfortable in dealing with a mucinous colorectal cancer than with an intestinal type. In our database, the survival of the two is exactly the same. But it's a very interesting thing that David is doing. Just an anecdote, I spent $500,000 of my own money about 20 years ago and imported the RF8 heat machine. And we treated about 50 patients with total abdominal heat, or heat plus mitomycin C. And we did see remarkable regressions of pseudomyxoma peritonei, and that was the good news. And the bad news was that we saw a a significant number of fistulae developing.
Mm.
And when the Japanese company that I was working with and I went to the FDA with a report of about 7% incidence of fistula,
Mm.
we got turned down. And they would not, it looked like we would never get an approval for this total abdominal heat for pseudomyxoma peritonei. So that wonderful big RF8 heat machine was scrapped.
Oh, if we had that now. Oh, what an artifact to have now.
Yeah, it would really go into the HIPEC museum.
It
No
would.
doubt about it. Yeah.
I'm pretty sure there's people that would pay $500,000 at least for it now, just for the value of it in that regard.
That could be. I don't know where it is. You have to ask president of the hospital center, who somehow or other got rid of it. Ken Salmon somehow or other got it. It was a huge, big machine.
Yeah.
But they did get rid of it somehow or other.
Well, so in this regard, clearly, and we in the patient community and at PMP Pals, we recognize your dedication, your singular drive to focus on this disease and the outcomes so diligently, recording the data and not giving up on us. We recognize that, and we are so grateful for that. That's not hyperbole. We recognize your contributions to our disease, and we would not be here without you. And going back to the BROMAC, right? I think your success has not just been about that persistence. It's been about integration too, right? Being brave enough to combine chemotherapeutic approaches as a surgical oncologist, and it's had miraculous results. And so perhaps BROMAC is just one more tool, as PPAC may be one day. And so we thank you truly for your dedication and not giving up, your persistence, and the amazing results you've had for us in our community. So you're very much like Gabriella Graham in that regard. If I don't like to take no for an answer, that's for sure. I might just say, Chris, that the initial entrance into this business came about as I examined my work with liver metastases. I don't know whether you realize it, but my initial experience with colorectal cancer, other than taking care of advanced primary malignancies, advanced rectal malignancies, I did a lot of that. But we back in the 1980s, we piloted at the NIH these protocols for resection of liver metastases. And way back then, in order to, everybody operates on the liver now, right? Liver metastases. Way back then, we had to have an informed consent to do surgery on patients who had colorectal or neuroendocrine metastases to the liver. And it was just amazing when I left the NIH, the liver metastases clinic was still full. I mean, those patients were just doing incredibly well. We had 40+% long-term survival. And I thought to myself, peritoneal metastases is considerably more complex. Rather than 1 or 2 or 3 metastatic sites, we may have 1,000. But why give up on surgery? And so we designed these peritoneectomy procedures and combined it with visceral resections. And then, of course, the idea of heated, well, first of all, I used the HIPEC. That was the original NIH treatment. But then due to the work in Japan, we put HIPEC and HIPEC together. And it was an evolution. The current problems in surgery that just came out this month. John Stewart is the first author, and the title of that there's about 350 references and about 55 pages in that. The title of it is
evolution of treatments for peritoneal surface malignancy. And it's a good title because it has been an evolution, and it's been a continuous improvement, I think, in the management of peritoneal metastases. When we first started publishing in the early 1980s, we would be the only articles. There was no other articles on the treatment of peritoneal metastases. And as a matter of fact, the most frequently cited journal article for peritoneal surface malignancy is one by Pierre Jacquet and myself. And it was published in a kind of a nondescript Italian journal. And why was it published in a nondescript Italian journal? Because it got rejected. The quantitative prognostic indicators for peritoneal surface malignancy, that's the CC score and the PCI, prior surgical score, and the use of it, they said, oh, this is not important. And every single surgical journal said, oh, this is not important. We're not going to publish this garbage. And so you have to reference this very unusual journal in order to go back and find out what are the prognostic indicators for pseudomyxoma peritonei, because way back when it was thought to be a non-entity. Definitely, but we wouldn't take no for an answer.
I want to share something with you real quick. This is, in our circles, this is a fun little joke that we recognize, but this is, so Armando Sardi shares this as in many of his presentations.
Oh yeah.
That's actually me. So
oh, yeah, right.
I went up the road and I actually had surgery with Armando Sardi. And
yes.
Yes. So anyways, that's my abdomen, right with the diagnostic incision for the removal of the appendix and the diseased phlegmon that was there at the time. But getting it all out, that's the most important part.
Yes, we don't really, there is somewhat of a hard look at HIPEC at this point in time. There are times when HIPEC is, I think, of incredible importance. When should you use, good question is, when should you use HIPEC? Well, if you've got free cancer cells within the peritoneal space, that's so-called positive peritoneal cytology, always will have it in PMP. I mean, sometimes it's more mucus than tumor cells, but if you look hard enough, you're going to always find cancer cells that can be identified by peritoneal cytology. That, same with mesothelioma, same with ovarian cancer, by the way. Ovarian cancer, serous ovarian cancer, that malignancy, for reasons I don't understand, is always shedding off large numbers of cells into the free peritoneal space, and there are some gastric cancers who do. Colon cancer, by the way, does not shed cancer cells into the free peritoneal space very often. Even patients who have gross peritoneal metastases, less than half of them have peritoneal, positive peritoneal cytology. So the question is, when does HIPEC work? Well, HIPEC works to prevent the reimplantation of free cancer cells into the operative site, in the abdominal incision or the laparoscopy port site or whatever. I'm convinced that HIPEC and irrigation, it's a large volume irrigation, very important in that regard. What about treating vascularized implants? Probably HIPEC doesn't work. You see, that's the big difference between pseudomyxoma, say, and colon cancer. One is a vascularized implant. The other is just the slime on the surface. So HIPEC, very, very impressive in our results with the non-invasive malignancies. And there's some ovarian malignancies and a few neuroendocrine tumors where we've removed tens of kilograms of tumor, of non-invasive tumor, washed with HIPEC, and we have a 20+ year survivor. And then you can have just a few implants of an invasive process, and the HIPEC doesn't work at all. So I think we're gonna be able to popularize this concept that HIPEC is not dead. The Prodigy 7 colon protocol would like to say, oh, HIPEC doesn't work. And I can tell you exactly why it didn't work in the Prodigy 7 protocol. There were no free cancer cells. Okay, and that's what you need in order to get a HIPEC good result.
Well, again, the persistence, the focus, right? You can't ignore either, right? So the free floating cytology, positive cytology, those cells, the vascularized implantations, the implants, right? You have to address them all in one shot, and it takes a lot of time and focus. How long was your longest procedure? Your longest HIPEC?
The longest procedure we had was a 17-hour procedure, and that was on a sarcoma. A young man, it was his third operation, and he went 17 hours, and I think he finally did succumb to his sarcoma about 4 years later.
Well, four years of extension as.
Yeah. Well, he was in the Army. He was a tough guy. But he had a huge surgical procedure, and of course, this concept of prior surgical score is very important. I mean, the old doctors would tell you, if you want to do well with cancer, you should have a perfect result on that first operation.
Yeah. Because
the surgery is a part of the natural history of the disease. And wherever you operate, you create a site of metastatic efficiency. And wherever you operate, that is the site where cancer is going to get caught in nooks and crannies and going to be stuck. And once those cancer cells stick, they're going to implant and grow. So the surgery is a part of the natural history of the disease. For example, if you have a right colon cancer and it's removed by a surgeon and then I operated 2 or 3 years later, you know where the site for largest amount of disease is? Resection site. And the same thing is true for sigmoid colon cancers. If you remove the sigmoid colon and there's peritoneal metastases there, and I go back 6 months, a year, 2 years later, the site for the largest volume of disease is right where the surgeon was working. So this concept in ovarian cancer is true also. We're just appalled at the number of needless hysterectomies that are done when you should try and preserve the uterus absolutely as much as possible to prevent this disease from settling down into the pelvis and growing out in and along the ureters and the vaginal cuff. So this tumor cell entrapment is a huge problem in the natural history of abdominal and pelvic malignancy. And at least a partial answer to that problem is HIPEC. And of course, we have 2 wonderful trials in ovarian cancer that shows HIPEC is of value, and strongly suggested in gastric cancer, a randomized controlled trial in this propensity matched trial of Bonet, strongly suggests that whenever you have these free gastric cancer cells, if you want to keep them from growing out right where the surgeon performed his gastrectomy, use HIPEC.
Brilliant. Well, as we start to wrap up the conversation, okay, and bringing it back to Gabriella, there's one more image I want to share with you. Like I said, this was the 2 of us in Salinas. There was a farm. We called it the Bunny Farm. I'm sure it has a different name than that, but they had a nice little shop and they sold lemonade and such. And we'd take the kids there to get pumpkins and those sorts of things. But I remember taking this picture with her. That's
a great picture.
It is a great picture. We believed in miracles then, and we believe in miracles now.
And where was this? This was in her home, or?
This was in Salinas, California, at a farm. We called it the Bunny Farm.
I see. Okay, I can see. It looks like a farm now that you. It looks like what's in the background is somewhat rural.
It's
Yeah.
it's a fun little store, a fun little shop. You can get hay rides and buy fresh vegetables. It's a great farm town. But yeah, that would be a day out with Gabriella. She was inspirational, never free of disease. Always refused pain medicines. Had countless blockages and refused morphine every time. She's a remarkable woman.
She really was. I don't know. She was what I call a surgical soldier. You know,
She was.
Really remarkable and resilient person.
She was. Wow.
Yep.
Well,
and
like
I think she was always believing that maybe that miracle would happen. And I wish it had. I wish it had.
Me too. And I was with her at the very end, and I can confirm, yeah, up until the very end, she was fighting. So God bless her.
Well, I would just say that where we're going right now is to, well, let me just tell you, the HIPECs in China are very interesting, Chris. HIPEC in China is 5 different installations every other day for the 10 days in and around the surgical event. So that if you have, say, gastric cancer with peritoneal metastases, you go in, you have your gastrectomy, and of course, they're so good at it. They do a gastrectomy like we do a hernia repair over there. They do the gastrectomy and you get HIPEC. And they lay the catheters in, and you go to intensive care unit for a few hours, and then you go to a special unit. And on postoperative day 2, so that's a 24-hour interval, you get another HIPEC. And again, you'll be evaluated, and you'll get up to 5 HIPECs, depending on the resilience of the patient and what they can tolerate. Of course, you can't. There's the old saying: "It's amazing what you can do for an alive patient." So you don't want to do somebody in by giving them too much chemotherapy. And the chemotherapies are reduced in dose, but this concept of peeling the onion, of taking down that cancer nodule a couple cell layers at a time is a reality. And then our own work that we're doing with collaborators in Spain is to put in a catheter actually that has 4 exit sites. And we're able to put this catheter in at the time of surgery. And then we can give 4 different installations at 3 weeks, 6 weeks, 9 weeks, and 12 weeks post-operatively. So we're actually trying to do what PPAC does, but do it in a much more economical way. And we're always using bidirectional chemotherapy. So the research, the new nuances in terms of delivery of NIPEC, normothermic intraperitoneal chemotherapy, combined with HIPEC. As I always say, HIPEC is necessary but not sufficient. HIPEC is necessary but not sufficient. So putting these catheters in on a regular basis for prolonged installation of chemotherapy, both intravenously and intraperitoneally, is for me the direction in which we're going to go to try and improve the outcome, say with a high grade appendiceal malignancy. And there's a really nice grant that's been given to pursue this. So we're really very active in pursuing this treatment modality.
Well, that's wonderful to hear, right? That the advances just keep coming.
They need.
Yep. That is incredibly encouraging. And I think what's one of the interesting things, I'd love to hear your comments on this too, right? Because obviously NIH, and they tried to complete a clinical trial, a blinded clinical trial that compared cytoreduction alone with cytoreduction plus HIPEC. If I understand that correctly, first let me ask that question. I believe they were trying to statistically prove that the HIPEC was better. Am I right or wrong about that?
No, the Stoyanovich-Esquivel protocol Is that what you're talking about that failed? That was systemic chemotherapy versus CRS and HIPEC.
Okay. I thought
The
NIH was doing,
the only one that's done CRS plus minus HIPEC
yes.
is the French trial, the Prodigy 7.
Okay. All right.
And that was done in colon. It has never been done in appendix. Whether it ever will be done or not, I don't know. I don't think that it will.
I don't think.
But it is, you know, we have these high volume centers now. Barcelona is doing, that's where Bajelic has gone. My former colleague, she's now a cytoreductive surgeon in Barcelona, Spain. They have 150 plus patients per year, and they could do some of these trials. And of course, it's expensive. Doing the clinical research is expensive, but also I'm really pushing Tom Cecil and Brendan Moran to try and get some, you know, I gave them the protocol 30 years ago, and they're still using that protocol. Well, I've moved on. I don't use that protocol at all anymore. So we need some active centers for research on peritoneal surface malignancy. There's a very interesting trial that's been started up in Germany now, and I think we're gonna. The Dutch, of course, are doing great things with ovarian cancer, and they've got a randomized trial now with mitomycin C. So we'll have some more very interesting data. There's no doubt about it. The data is continuing to be accumulated.
Amazing. Well, there's always more to talk about every year at the symposiums.
Yep.
And so we're looking forward to Beijing and now Venice as well. And well, thank you again for all that you've done and your contributions. I've learned today what kindred spirits you and Gabriella were with persistence and not giving up, and we're grateful for that. So
she was a force to be reckoned with. I'm just persistent. I have to say I'm convinced that patience and persistence are the for me to last 31 years at the Washington Hospital Center. It took a lot of patience and persistence, let me tell you.
Yeah.
But that is the key ingredient into getting this done. And you would be amazed at the really interesting things that are going on right now, and not only in Europe, but really all over the world. This concept of long-term intraperitoneal paclitaxel, really powerful tool, and it just needs a couple more clinical trials before it comes into usage.
Okay.
Yeah. So there's a lot of interesting things happen. That's the magic drug, actually, is paclitaxel.
Okay. Well, these are the advances that give patients hope.
Yep.
And without hope, it's a tough road. So hope is what we do.
Yeah. Without hope, the people perish. I don't know who said that, but it's true.
Yeah. Well, thank you for your part.
Okay.
We'll continue doing our part. It's been a true pleasure. Thank you very much for your time.
All right, Chris. I think you've got plenty of information here.
Oh, we've got tons.
If you need any more, give me a call back.
I will, Dr. Sugarbaker. Thank you. Have a great day. Thank Ilsa also. We appreciate it.
All right, will do. Yeah. I'll go have a cup of coffee with her right now.
Very good. Have a great day.
Sure
Bye-bye.
enough. Thanks for the interview. Bye-bye.
You bet.